You go to the doctor every year, you get your blood work done, you schedule your screenings. You do everything you are told a responsible, health-conscious adult should do, and you feel good about it, like you are taking charge of your health, catching problems early, and giving yourself the best chance at a long, healthy life. But what if I told you that some of those screenings, tests you have been getting faithfully for years, tests your doctor may still be ordering out of habit, might actually be doing you more harm than good after the age of 60? What if the very tests designed to save your life could be leading to unnecessary surgeries, dangerous procedures, psychological distress, and treatments for conditions that would never have caused you a single day of trouble? This is not anti-medicine propaganda. This is evidence-based medicine at its most honest. And today I'm going to walk you through 5 medical screenings that major medical organizations, including the United States Preventive Services Task Force, the American Cancer Society, and the American College of Physicians, have flagged as potentially harmful for older adults when performed without careful consideration of individual risk, life expectancy, and the very real phenomenon of overdiagnosis. The first screening that may cause more harm than good after 60 is the PSA test for prostate cancer. The prostate-specific antigen test has been one of the most controversial screenings in modern medicine for over 2 decades, and the controversy centers on a single devastating reality. Most prostate cancers detected by PSA screening are slow-growing tumors that will never cause symptoms, never spread, and never kill the patient. But once detected, they are almost always treated, and the treatments carry serious, life-altering side effects. Prostate cancer is extremely common in older men. Autopsy studies have shown that approximately 50% of men in their 70s and 80% of men in their 80s have prostate cancer cells present in their prostate gland. The vast majority of these cancers are indolent. They grow so slowly that the men die of other causes long before the cancer would ever become clinically significant. PSA screening finds many of these cancers, labels the men as cancer patients, and sets in motion a cascade of biopsies, imaging, anxiety, and treatment decisions that can dramatically reduce quality of life. The treatments for prostate cancer, radical prostatectomy, and radiation therapy, carry significant risks of urinary incontinence, erectile dysfunction, bowel problems, and chronic pain. These are not rare complications. They are common outcomes that affect a substantial percentage of treated patients. For a 75-year-old man with a slow-growing prostate cancer that would never have affected his health, undergoing surgery or radiation that leaves him incontinent and impotent represents a net harm, not a net benefit. The United States Preventive Services Task Force recommends that men over 70 should not be routinely screened with PSA testing. For men between 55 and 69, the decision should be an individual one made in consultation with a physician, weighing the potential benefits against the substantial risks of overdiagnosis and overtreatment. If you are over 60 and your doctor orders a PSA test without discussing these trade-offs with you, ask questions. Ask about the likelihood of finding a cancer that would actually threaten your life versus finding one that would never cause problems. Ask about the false positive rate and what happens after an abnormal result. And ask whether watchful waiting or active surveillance, monitoring the cancer without treating it unless it shows signs of progression, might be appropriate if cancer is detected. The second screening that may cause more harm than good is routine mammography after age 75. Breast cancer screening with mammography has saved many lives, and I want to be clear that I am not suggesting mammography is harmful for all women at all ages. For women between 50 and 74, the evidence strongly supports regular mammography screening. But after 75, the calculus changes significantly. The benefit of cancer screening depends on life expectancy. Screening works by detecting cancer early enough that treatment can extend life. But if a woman's life expectancy is less than 10 years due to age and comorbidities, the cancer detected by screening may never have time to progress to a point where it would affect her health. Meanwhile, the screening itself can cause harm through false positive results that trigger anxiety, additional imaging, biopsies, and sometimes unnecessary surgery. Mammography has a false positive rate of approximately 10 to 12% per screening round. For a woman who has been screened annually since age 50, the cumulative probability of at least one false positive result over her screening lifetime approaches 50%. Each false positive triggers a cascade of follow-up. Additional mammographic views, ultrasound, and frequently biopsy. That carries physical discomfort, emotional distress, and medical costs. Overdiagnosis is also a significant concern. Mammography can detect ductal carcinoma in situ, a condition that is classified as cancer, but in many cases would never progress to invasive disease. Treatment of ductal carcinoma in situ typically involves surgery, and sometimes radiation and hormonal therapy for a condition that may have remained harmless for the rest of the woman's life. Estimates suggest that approximately 20 to 30% of breast cancers detected by mammography screening represent overdiagnosis. The American Cancer Society recommends that women with a life expectancy of less than 10 years should discuss discontinuing mammography screening with their doctor. The decision should be individualized based on overall health, comorbidities, personal preferences, and family history. A healthy, active 80-year-old with no major medical conditions may still benefit from screening, while a 70-year-old with advanced heart disease and diabetes may not. The third screening that may cause more harm than good is colonoscopy, after age 75. Colorectal cancer screening has been one of the great public health successes of the past several decades, preventing thousands of cancer deaths through the detection and removal of precancerous polyps. But like all screening tests, colonoscopy has diminishing returns with advancing age and increasing risks. The procedure itself carries risks that increase with age. Colonoscopy requires bowel preparation, typically a large volume of laxative solution that causes profuse diarrhea, which can lead to dehydration, electrolyte imbalances, and kidney injury in older adults. The sedation used during the procedure carries risks of respiratory depression, cardiovascular complications, and prolonged cognitive effects in seniors. And the procedure itself carries a risk of bowel perforation, a life-threatening complication that requires emergency surgery. With rates that increase with age and comorbidity, the benefit of colonoscopy screening decreases after 75 because colorectal cancer typically takes 10 to 15 years to develop from a precancerous polyp to invasive cancer. For an individual with a life expectancy of less than 10 years, finding and removing a precancerous polyp today is unlikely to prevent a cancer death because the cancer would not have developed within their remaining lifespan. Meanwhile, the immediate risks of the procedure are real and present. The United States Preventive Services Task Force recommends that colorectal cancer screening should be an individual decision for adults aged 76 to 85, taking into account overall health, prior screening history, and personal preferences. Adults over 85 should generally not be screened. If you have been regularly screened throughout your 50s and 60s with normal results, the probability of developing colorectal cancer in your remaining years is very low, and the risks of continued screening may outweigh the benefits. Non-invasive alternatives to colonoscopy, including fecal immunochemical testing and stool DNA testing, offer lower-risk screening options for older adults who still wish to be screened. These stool-based tests can detect many colorectal cancers and advanced polyps without the procedural risks of colonoscopy, though they do have higher rates of false positive results and may still lead to colonoscopy for follow-up. The fourth screening that may cause more harm than good is routine thyroid cancer screening with ultrasound. Thyroid cancer screening has become increasingly common, driven in part by the availability of high-resolution ultrasound technology that can detect tiny thyroid nodules invisible to physical examination. The result has been what many experts describe as an epidemic of thyroid cancer diagnosis, without a corresponding epidemic of thyroid cancer death. The very definition of overdiagnosis. The incidence of thyroid cancer has tripled over the past 3 decades, but the mortality rate has remained essentially unchanged. This means we are finding vastly more thyroid cancers, but not saving more lives. We are simply detecting small, indolent cancers that would never have caused harm and treating them with surgery, radioactive iodine therapy, and lifelong thyroid hormone replacement, all of which carry side effects and reduce quality of life. Thyroid surgery carries risks of damage to the recurrent laryngeal nerve, which controls the vocal cords, potentially causing permanent hoarseness or voice changes. It also carries a risk of hypoparathyroidism, damage to the parathyroid glands that regulate calcium metabolism, which can cause lifelong problems with calcium levels that require daily supplementation and monitoring. For a small, slow-growing thyroid cancer that would never have caused symptoms, these surgical risks represent clear harm without corresponding benefit. The United States Preventive Services Task Force recommends against screening for thyroid cancer in asymptomatic adults. This recommendation applies to all ages, but is particularly relevant for seniors, in whom small thyroid cancers are extremely common. Autopsy studies have found thyroid cancer in approximately 10 to 30% of people who died of other causes without ever knowing they had thyroid cancer. If your doctor discovers a thyroid nodule incidentally during examination or imaging for another purpose, discuss the risks and benefits of further evaluation carefully. Many small thyroid nodules can be monitored with periodic ultrasound rather than immediately biopsied and treated. The fifth screening that may cause more harm than good is routine full-body skin checks for melanoma in low-risk individuals. Skin cancer is the most common cancer in the United States, and melanoma bicontiida, the most dangerous form, kills approximately 8,000 Americans per year. Early detection of melanoma through skin examination is critically important for high-risk individuals. But routine full-body skin checks by dermatologists in average-risk older adults have not been shown to reduce melanoma mortality in randomized controlled trials, and they can lead to overdiagnosis and overtreatment of lesions that would never have become dangerous. The concern centers on the detection of thin melanomas and melanoma in situ, very early-stage lesions that have an excellent prognosis regardless of how they are detected. Screening finds more of these indolent lesions without necessarily finding additional, thick, aggressive melanomas that are the ones responsible for melanoma deaths. Meanwhile, the biopsies performed to evaluate suspicious lesions can cause scarring, infection, and anxiety, and the excisions performed to treat early-stage lesions that may never have progressed carry surgical risks. The United States Preventive Services Task Force has concluded that the current evidence is insufficient to recommend for or against routine skin cancer screening in asymptomatic adults. This does not mean you should ignore your skin. It means that the most effective approach is self-awareness rather than routine screening. Learn to recognize the warning signs of melanoma using the ABCDE criteria: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution or change over time. Perform monthly self-examinations and see a dermatologist promptly if you notice any mole that is changing in size, shape or color, or any new skin lesion that looks different from your other moles. High-risk individuals, those with a history of melanoma, a family history of melanoma, a large number of moles, atypical moles, or a history of severe sunburns, should continue regular dermatologic surveillance regardless of age. The screening concerns I described apply primarily to average-risk individuals. Now let me tie all 5 screenings together with the overarching concept that makes this conversation so important: the concept of overdiagnosis. Overdiagnosis occurs when screening detects a condition that is real. It is not a false positive, but that would never have caused symptoms, required treatment, or shortened life if it had remained undetected. Overdiagnosis turns healthy people into patients. It subjects them to the anxiety of a diagnosis, the risks of treatment, and the lifelong burden of being labelled with a disease, all for a condition that was never going to harm them. Overdiagnosis is not a failure of the screening test. The test correctly identified an abnormality. The problem is that not all abnormalities are created equal. Some cancers grow rapidly, spread aggressively, and kill if not caught early. Others grow so slowly that they never reach a clinically significant stage within a human lifespan. Screening finds both types, but we currently lack the ability to reliably distinguish between them at the time of detection. So we treat them all, accepting that some patients will be harmed by treatment for a cancer that was never going to hurt them in order to ensure that the dangerous cancers are caught and treated. The balance between benefit and harm shifts as you age. For a 50-year-old with a 30-year life expectancy, the benefit of catching an early cancer is substantial because there is plenty of time for that cancer to grow and become dangerous. For an 80-year-old with a 5-year life expectancy, the same cancer is unlikely to progress enough to cause harm, and the risks of detection and treatment may outweigh any potential benefit. This does not mean you should stop seeing your doctor or refuse all medical testing after 60. It means you should have an informed, thoughtful conversation with your physician about which screenings are appropriate for you as an individual, based on your age, your health status, your life expectancy, your family history, your personal values, and your tolerance for risk. Medicine is not one size fits all, and the screening recommendations that were right for you at 50 may not be right for you at 75. Ask your doctor 3 questions before agreeing to any screening test. First, what is the probability that this test will find something that would actually threaten my life? Second, what happens if the test is positive? What further tests, procedures, and treatments will follow? And third, what are the risks of those follow-up procedures and treatments? And how do they compare to the risk of the condition I am being screened for? These questions are not adversarial. They are the foundation of shared decision-making, the collaborative process by which you and your doctor arrive at medical decisions that reflect both the best available evidence and your personal values and preferences. A good doctor will welcome these questions and provide honest, nuanced answers. Share this information with every senior you know. The 5 screenings I discussed today: PSA testing, mammography after 75, colonoscopy after 75, thyroid cancer screening, and routine full-body skin checks, are all examples of well-intentioned medical practices that can cause harm when applied indiscriminately to older adults. Understanding the concept of overdiagnosis and engaging in shared decision-making with your physician are the keys to navigating screening decisions wisely. Subscribe for more evidence-based health content and drop a comment below with your questions or experiences. I read every single one. Stay informed, ask questions, and take charge of your health thoughtfully. The concept of lead time bias is essential for understanding why screening statistics can be misleading. Lead time bias occurs when screening detects a disease earlier than it would have been detected through symptoms, making it appear that screened patients survive longer after diagnosis even if screening does not actually extend their total lifespan. For example, if a cancer is detected by screening 2 years before it would have caused symptoms, and the patient dies at the same time they would have died without screening, the screened patient appears to have survived 2 years longer after diagnosis, but their total lifespan is unchanged. They simply knew about the cancer for 2 extra years, living with the burden of diagnosis, treatment, and anxiety for a longer period without any actual survival benefit. Understanding lead time bias is critical for interpreting the claims made about screening test and for making informed decisions about whether a particular test is likely to provide genuine benefit or merely earlier knowledge of an inevitable outcome. Length time bias is another statistical phenomenon that inflates the apparent benefit of screening programs. Length time bias occurs because screening is more likely to detect slow-growing, less aggressive cancers than fast-growing aggressive ones. Slow-growing cancers are present for longer periods before causing symptoms, which means there is a larger window of time during which screening can find them. Fast-growing cancers, by contrast, develop and become symptomatic quickly, often between scheduled screening appointments. The result is that screened populations appear to have better cancer survival rates, not because screening saved their lives, but because screening preferentially detected the less dangerous cancers that had good prognoses regardless of when they were found. This is particularly relevant for older adults, in whom slow-growing, indolent cancers are extremely common and rarely cause harm within a normal remaining lifespan. The financial dimension of overdiagnosis and unnecessary screening deserves acknowledgement because it affects seniors on fixed incomes who may be paying substantial out-of-pocket costs for tests and follow-up procedures that provide no health benefit. Even with Medicare coverage, the co-payments, deductibles, and indirect costs associated with screening tests, follow-up imaging, biopsies, specialist consultations, and treatments for overdiagnosed conditions can be financially burdensome. The time spent travelling to appointments, waiting in medical offices, and recovering from procedures represents an additional cost in quality of life that is rarely factored into screening recommendations. When a screening test is unlikely to provide meaningful health benefit for an individual patient because of age, comorbidities, or limited life expectancy, the financial and time costs of that test and its downstream consequences represent pure waste. The psychological burden of overdiagnosis extends beyond the initial anxiety of receiving a diagnosis. Patients who are told they have cancer, even a slow-growing, indolent cancer that would never have caused harm, often experience lasting psychological effects including chronic anxiety, depression, fear of recurrence, hypervigilance about physical symptoms, and a fundamental shift in how they perceive themselves and their mortality. Research on patients diagnosed with low-risk thyroid cancer and ductal carcinoma in situ of the breast has documented significant reductions in quality of life, increased healthcare utilization, and persistent cancer-related worry that persists for years after treatment, even when the prognosis is excellent. For seniors who are already navigating the psychological challenges of aging, including loss of independence, bereavement, and chronic illness, the added burden of a cancer diagnosis that was never going to affect their health represents a substantial and entirely preventable harm. Active surveillance, the strategy of monitoring a detected condition without immediate treatment, has emerged as an increasingly accepted alternative to immediate intervention for many slow-growing cancers found through screening. In prostate cancer, active surveillance protocols involve regular PSA testing, periodic biopsies, and clinical monitoring to track the cancer's behavior over time. Treatment is initiated only if the cancer shows signs of progression, increasing PSA velocity, upgrading of biopsy grade, or development of symptoms. Studies with 15 to 20 years of follow-up have demonstrated that active surveillance is a safe strategy for low-risk prostate cancer, with cancer-specific survival rates exceeding 98%. Similar approaches are being developed for low-risk thyroid cancer and ductal carcinoma in situ. For seniors considering screening, knowing that active surveillance is available as an alternative to immediate treatment can make the decision to be screened less anxiety-provoking, because a positive result does not automatically commit them to surgery or radiation.